Welcome, doctors and healthcare professionals, to Maternal Matters, optimizing nutrition from preconception to future generations, where we're about to dive deep into the crucial nutritional pillars that every aspiring mother must go through from conception to her postpartum days. To guide us through our discussion, please welcome your moderator. He is a renowned doctor and medical director of the Cato Repro Biotech Center, Dr. Richie Mendiola.
Welcome, my fellow doctors, to Maternal Matters. Today, we'll be joined by global experts as they take us through the crucial nutritional milestones that every mother and mother-to-be needs in order to successfully traverse their pregnancy journey. Hopefully, with the insights we'll gain today, we'll all be able to influence more positive nutritional practices, not just for our current patients, but also for future generations. Before that, though, let's take a quick look at the current concerns and confusions that women have as they go through every stage of pregnancy.
From the moment she starts trying to conceive, every woman has taken the first steps of her motherhood journey. A journey that is rife with challenges and deficiencies that could not only negatively impact themselves, but also their future children. During their preconception days, are they aware of the proper diet and supplementation to keep their bodies in the prime condition to conceive? Do they know the metabolic risks involved with common issues like obesity, diabetes, or polycystic ovarian syndrome? Once they get pregnant, do they know about the metabolic changes their bodies will go through? How well do they understand the nutritional needs of each trimester to support their overall health and that of their babies? Especially during difficult or complicated pregnancies, are they prepared to properly nourish their bodies through such a stressful ordeal? Are women from low to middle income countries aware of which public guidelines can best meet their specific metabolic needs? With so many lingering confusions and challenges faced by mothers and mothers-to-be across the globe, where do we now come in? How can we, as healthcare professionals, safeguard their proper health and nutrition, as well as ensure the overall well-being of not just the women in our care, but also of the future generations to come? Tonight, we tackle all that and more as we discuss Maternal Matters.
There's still so much that women all over the globe don't know when it comes to how to care for their bodies and their health as they go through their own pregnancy journeys. This is why, as doctors, it is our duty to offer them our expert advice and guidance in order to nourish not just their overall health and safety, but those of future generations as well. For that, we have our esteemed global experts here with us today to share their insights and knowledge with all of our viewers. The first is a registered dietitian nutritionist and researcher, a coordinator for the Clinical Nutrition Master's Program, and a coordinator for the Nutrition and Bioprogramming Coordination of the Instituto Nacional de Perinatología in Mexico City, here to discuss the risks for metabolic health, proper diet before pregnancy, proper supplementation during preconception. Please welcome Dr. Otilia Perichart Pereira.
Thank you very much. I'm going to speak about good nutrition before pregnancy, an opportunity to decrease metabolic risk and prevent chronic diseases. We have very high prevalence of obesity in women worldwide. We have in the Americas almost more than 30% of obesity in women, and it has been estimated that in 2030 obesity will be on 20% around the world. So really it has been increasing and with not stopping. And we have very high risk of metabolic syndrome, type 2 diabetes, cardiovascular disease, and also of perinatal complications associated with obesity. We also have high prevalence of diabetes is 2019, and we have the yellow and oranges countries with the highest prevalence. So really we need to improve this metabolic health. We have also a very relevant metabolic issue in women, that it's polycystic ovarian syndrome, that affects 15 to 20% of women, and it's hormonal imbalances, inflammation, and also metabolic alterations. And what is important is that besides infertility, we have documentation of higher risk of adverse pregnancy outcomes. You can see here all of them are highest in women with PCOS, and also postpartum complications, as you can see in the right table. So lifestyle is the first line of treatment, and nutrition also oriented interventions. We also have high prevalence of anemia in women, which 50% of this anemia will be iron deficiency related, with very high risk of low birth weight, preterm birth, among others. And also we have very high prevalence anemia in these red countries, and mid-pink moderate anemia with 20 to 40% prevalence. We also have unhealthy diets that are generally low in micronutrient, low in fiber, with added sugars, added fat, and high content of energy that are not helping in this metabolic and inflammation context. We have very high prevalence of some micronutrient deficiencies. The two more common are iron deficiency and iodine deficiency, with in females, iodine deficiency also being an important group because of the risk of miscarriages, stillbirth, congenital malformations. Even though we don't have good estimations of folate deficiencies or zinc deficiency, we do know that only 30% of women take folic acid supplements before conception, and also that 70% of people around the world have zinc deficient diets. Another issue is that probably many nutrients deficiency are multiple or are come together, and we have these problems of hidden hunger, food insecurity, that also are relevant and important to take into account. So one mineral that is important because of its role in growth and also in preeclampsia in pregnancy, intake of calcium. So it's lower in women, and we are not achieving the 1,000 milligrams per day. You can see the green countries are the ones that are achieving or near achieving a good intake, and the others are low. Mainly Northern Europe have adequate intakes, and Asia has very, very low intakes. So this is important. Vitamin D deficiency is also a global problem in adults and also in pregnant women. In these red circles, we can see the prevalences in the general population in different areas of the world. And we know that starting a pregnancy with low levels of vitamin D increases the risk of gestational diabetes. You can see here 1.8 more times of having the disease when we have 25 OHD concentrations low. And also these concentrations are inversely related with glycated hemoglobin, with fasting glucose, and with HOMA. We also have other meta-analyses with moderate evidence that states also higher risk of gestational diabetes. And for preeclampsia, we don't have very good certainty evidence, but we have some reports that increasing the risk of preeclampsia with low vitamin D levels. And vitamin D has a role in metabolic health and in many processes that are related with good vascular and good placentation and good calcium or bone mineral metabolism, and also with improved carbohydrate metabolism, higher insulin, lower insulin resistance, lower inflammation, lower oxidative stress. So really vitamin D is important to decrease the deficiency before pregnancy. And also just to talk a little bit about B complex, we need these methyl donors for epigenetic changes. And this is the methyl donor cycle where choline, B12, folate, B6 play a role. And this is very important in early stage of from conception to the early stage of pregnancy. So a good B complex status is needed also. So we're starting pregnancy not very healthy, with an environment that is not helping for the metabolic health, with probably undernutrition or micronutrient deficiencies, and also with a metabolic profile high-risk metabolic profile with COVID probably, and we have higher prevalences or incidence of some complications as preeclampsia or gestational diabetes, intrauterine growth, fetal growth that is impaired, and altered infant size or newborn size, and that increases the risk of chronic diseases, and this is metabolic programming. So it's important to start early where there's high plasticity, high epigenetic changes, and where risk will really be decreased, and early, probably before these 1,000 days of life on the reproductive age. That will be an opportunity, and this has been stated by the International Federation of Gynecology and Obstetrics, to think nutrition first and to try to focus maternal nutrition on a life course approach, and to give a standard care that will have an emphasis on lifestyle and nutrition. So speaking about healthy eating will be important to promote better diets. And I'm going to speak about the DASH diet that is very high in fruit, vegetables, and low-fat dairy. And this DASH diet has been associated with lower risk of cardiovascular disease, type 2 diabetes, coronary heart disease, is the best diet for hypertension and to decrease blood pressure, and also total cholesterol and LDL cholesterol. Adherence to the DASH diet in early pregnancy, it has not been studied very much before pregnancy or before conception, but it has been associated with lower risk of gestational diabetes, and also dietary fiber, cereal fiber, or good consumption of calcium, more than 795 milligrams per day, will be related with a decrease of gestational diabetes risk. Folate, iron, choline, omega-3 rich diets are needed in pregnancy, so we should focus also in these nutrients. Mediterranean type dietary patterns, that has been more studied before pregnancy and on reproductive age, with positive effects in glycemia, insulin sensitivity, triglycerides, or glycated hemoglobin. And also it has been shown that a high adherence to this type of diet will reduce the risk of hypertensive disorders and lower the risk of gestational diabetes. A fast food intake, higher fast food intake, also increase the risk of gestational diabetes. So we have all these associations that are related with functional components that are important, such as healthy carbs from legumes, from fruits and vegetables, from some dairy. If we're talking about the DASH diet, we're talking about low glycemic index and fiber. And we're also talking about good fat, monounsaturated fat from nuts and seeds, from olive oil, avocado, and omega-3 from fatty fish or fish, and some nuts also. And we're talking about a lot of vitamins, minerals, and antioxidants, which will have anti-inflammatory properties, antioxidant, lower peaks of glycemia, and have prebiotic and probiotic roles. So we need healthy fats. Here's the image. We need to decrease unhealthy fats, saturated fats, and increase omega-3 and essential fatty acids, because these will be pro-oxidative and inflammatory. We have low intakes of DHA and arachidonic acid around the world. You can see that we need around 500 milligrams of DHA, and we are not achieving that. The sources will be fish. That's the best form of achieving a good omega-3 status. We need to improve our omega-3, omega-6 dietary intake ratio, and increasing oily fish to 300 or 350 grams per day of fatty fish per day, no, per week, I'm sorry, will be good to improve our intake. And we know also that DHA and arachidonic acid have very important roles in visual and cognitive development of the fetus. So these are very important nutrients on early gestation. And on the third trimester, they accumulate primarily on these tissues. So we know that this transfer from placenta to umbilical cord is altered in gestational diabetes and is altered in preeclampsia. And we also know that women with obesity have more risk of having low concentrations of these essential fatty acids and a bad omega-3 status. What about carbohydrates? We want healthy carbohydrates, high fiber, low glycemic, no added sugars, which are no pro-oxidative or inflammatory or are more anti-inflammatory. So we should promote those. And we also know that this type of dietary patterns that I have been describing increasing the amount of my microorganism in the microbiota, improves the functional intestinal barrier, regulated immune response, probably via the synthesis of short-chain fatty acids when you use fiber, prebiotics, etc. And also we will have less lipopolysaccharide and less pro-inflammatory cytokines. And it has been demonstrated, and research is going on, but Mediterranean diet has higher diversity and higher microorganisms. And maternal microbial alterations have been linked also to some adverse infant or fetal outcomes. So individual supplementation will be needed. At the clinical level, we will need to assess well risk factors for deficiency, what doses, what nutrients, multivitamin, and the population level also what is the prevalence of some deficiencies, how much food insecurity there is, fortification in that region, etc. There's very few research about supplementation specifically in women of reproductive age. Intermittent iron has been studied, and this is a Cochrane review, where intermittent supplementation of iron increases hemoglobin significantly and also reduces the risk of anemia in women of reproductive age. And there's no clear effect if it's improved iron deficiency or iron deficiency anemia. Anemia in general, it's improved, and no differences with daily supplementation. So probably intermittent supplementation is a good option. All women planning a pregnancy would need folic acid to decrease neural tube defect risk or incidence, 400 micrograms per day. And there has been a lot of controversy about the doses in high-risk women. Just released a guideline from the Society of Obstetricians and Gynecologists of Canada, where they state that for high-risk women, 4 to 5 milligrams per day, moderate risk 1 milligram per day, and low risk 400 micrograms. But only for the high risk and moderate risk will be up to 12 weeks of gestation, preconception, and up to 12 weeks. After that, it should be returned to low dose, and that's key. And another change or significant recommendation is that the three categories should be taken within a multivitamin, the folic acid with B12 and iron supplementation. And it depends, if you need more folic acid, probably you take it alone, additional to the multivitamin, and here you change the doses of folic acid. So this is really new, and it's really good, that paper. And recommended intakes or supplementation doses for vitamin D, really not clear. If there are deficiencies, it's more clear the level of supplementation. If not, really we need to be clear on what doses will be recommended. We need to be clear if there's obesity, if there's no sun exposure, if there's dietary deficiencies or vegan, probably will need to supplement vitamin D. And well, that will be all. The key points is that we need adequate nutrition and metabolic status of the mother. We want to prevent diabetes, we want to prevent polycystic ovarian syndrome and have good weight, glucose, lipid, insulins, avoid inflammation. We want healthy eating, but to achieve healthy eating, we need counseling, and we want supplementation individualized depending on risk factors for deficiency, already detected deficiencies, or probably not dietary intakes adequate as DHA, as calcium, and probably intermittent iron supplementation in high menstruating women or in high prevalence areas. Thank you very much for your attention.
Thank you so much, Dr. Otilia, for sharing all these valuable insights with us. There are a lot of potential metabolic risks and hurdles that women across the globe go through in their attempts to become pregnant. But luckily, the latest in evidence-based research shows us the path to the proper nutritional steps and supplementation needed to avoid these risks. Coming from this newfound knowledge, let us take it a step further as we tackle the next stage in pregnancy with our second global expert. He is a professor of obstetrics and gynecology and maternal fetal medicine, a coordinator of the Reproductive and Perinatal Medicine Center at the University of Perugia, and founder and director of the Permanent International and European School of Perinatal and Reproductive Medicine in Florence. Here to discuss the nutritional issues women face during pregnancy, as well as the proper diet and supplementation needed by pregnant women as their bodies go through these changes. Please welcome Dr. Giancarlo Di Renzo.
Dear colleagues, from all over the world where you are, we are connected by the two-dimensional system nowadays, most popular. And today I'm addressing the issue of what is important, what are the most crucial nutrients for pregnancy. Let me first say that the woman undergo physiological changes during pregnancy, which are not affecting the homeostasis of the body, increasing metabolic rate, increasing energy requirements, but also she needs the increased intake of certain nutrients, particularly, as you can see here, iron, folate, and so on, which are more or less known to everybody. When we look at the specific recommendation that are given compared to the normal reproductive period of a woman of the macronutrients which are needed in pregnancy, of course, many vitamins, minerals, so on, need to be increased from 10 to 50, 60%. And as you can notice here, I will address more specifically. What is happening in pregnancy is that many studies done in the last decades have linked either the maternal weight, which is an indirect, of course, signal of the behavior, of the lifestyle or nutrition of a woman, or the nutrition itself during pregnancy, with many maternal and fetal changes. They are depicted in this slide, but I would like to draw your attention to the first link that we have with a fetus, which is fetal malformation loss. What does it mean? This means that diet can affect the incidence of a specific fetal malformation. So there are components of the diet that can be teratogenic. And this is a very important issue that has been very much undervalued in the last year. We know for sure that some kind of diet, particularly the Western, the rich of carbons and so on, have been linked with an increased risk of cardiovascular malformation, of a cleft palate, of spina bifida and so on, compared to the so-called Mediterranean diet, which has a much lower incidence of these defects. With all the possible confounders, in any case, this slide indicates that there are ways to influence the maternal status during pregnancy and pregnancy itself by modifying the nutrition. And of course, the quality is crucial. Therefore, many societies in the last 2 decades have raised recommendation for dietary reference intakes, which you can see here, because the need, as I said at the beginning, are increased for many of them. Unfortunately, these recommendations have not been followed by the observation that around the world the diet has been adequate, particularly in pregnancy. But as you can see here, there is a lot of nutritional gaps which are interesting, many micronutrients, many minerals, many vitamins. And this deficiency, of course, should be addressed because some of them are linked with major problems. This is what is recommended, for instance, by the major international association, which is the FIGO, in the preconceptional period to prepare the mother, and of course during the different trimester and the breastfeeding period. You can see that the supplementation, or at least a diet which is rich of particularly minerals and vitamins, is found to be appropriate because this can modify the outcome of pregnancy. There are 2 axioms which have been always considered by the obstetrician midwife around the world. that the fetus is a perfect parasite and need protection because the nutritional damage which may be inflicted to the mother pass to the fetus as well, because of course the placenta is a filter which protects, but up to a certain level, the substances which are going through the maternal body to the fetal body. Now, many of these concepts have been changed, but more or less, of course, we have to consider the fetus as a parasite that may receive the good and the bad from the mother. So the lifestyle and nutrition of the mother is particularly important and affect the fetus. And this not only as a result, immediate result we can see at birth, but we know very well from all the concepts that have been raised from the developmental origin of health and disease that everything that can happen during pregnancy can influence the health of the adult. And the nutrients and the toxic chemicals which are passing to the fetus through the nutrients have a gross influence on this. Just think at an experiment in nature, which is so striking that everybody can understand. A bee has no difference from the queen bee as far as genetics is concerned. But the queen bee is a normal bee which is nourished in the royal jelly. And with epigenetic changes which are derived by the nutrition and the nutrients contained in the royal jelly, the queen bee is by far much bigger of the normal bee and is fertile, while the normal bees are not fertile. So this is a classical experimental which show how careful we should have to the diet in order to provide an intake, particular macro and micronutrients, which afford for an healthy pregnancy an optimal perinatal outcome. And of course, we have recommendation, which is the best diet during pregnancy, the one with ample quantities of vegetable, fruit, whole grains, nuts, legumes, and so on. And we have to try to avoid at least those which are rich of processed foods, simple sugar, and of course, saturated fats. Now, let me address more specifically three aspects. The first is iron, the second is the iodine, and the third is the omega-3. It is unquestionable that anemia is a public health problem around the world. The degree of anemia in women is particularly elevated, and we know that at least in the world, 40 to 60% of women in pregnancy suffer of various degrees of anemia, okay? This is an important problem because it is the basis for the severe risk that the woman may have during the delivery, particularly with increased risk of postpartum hemorrhage, which may cause up to 23% of maternal death. And severe anemia is one of the factors that contribute to this, but not only, because it is a problem also for the neonate, for the adult life, because iron deficiency anemia may produce long-lasting defects in mental development. You know that myelinization depends very much from the iron, and of course, the babies which are born from severely anemic mother may suffer in adult life of cardiovascular higher mortality. So the strategy to reduce the impact of iron deficiency, which is the most important, at least a cause of anemia, there are of course many others, but 60% is mainly iron dependent, is to prevent with the appropriate date, to screen of course the mother, this doesn't happen in many parts of the world, to supplement, and of course for the baby to delay cord clamping and delivery, although this has been disputed a lot, but for either for the preterm baby, either for the term baby, 30 to 60 seconds of waiting before cutting the cord is beneficial, at least in 70-80% of cases. And of course, check afterwards if what we give, if our strategies are good. What are the strategies we may use? Supplementation, of course, giving iron supplement, diversifying the diet, promoting the diet which is full or rich of iron, fortifying the food. This is being attempted in some, at least, area of the world, and particularly control infection. Some gastrointestinal worm infection, of course, they decrease, or some gastroenteritis, they decrease the uptake of iron. And the problems, however, with the supplementation of iron are not solved easily, particularly with the oral iron supplements, because, of course, iron is a very difficult mineral to be absorbed, and is very dangerous to remain as it is in the cells. So the side effects that can give the supplementation of iron prevent a high compliance in women. You see that almost 40% after initiating iron supplementation don't continue, or they even don't continue, don't tell the doctor that they are not taking the supplementation anymore. So we have to be careful to check after 1 month if hemoglobin has improved. Otherwise, we have to find another way also with iron supplementation by intravenous route. FIGO advise iron supplementation with a minimum of 30 milligrams a day as a preventive tool, so with a normal ferritin value, normal hemoglobin value, but of course we need much more for the treatment. And of course the association of iron with the vitamin C and some particular food is much better, because you know that iron has absorption very low in our gastrointestinal tract, and can be enhanced only with associations of food and can be impaired by the other food. Let me now briefly speak about iodine, because iodine has more or less a similar picture as iron. But of course, we consider that in the world, less than 100 micrograms per liter of concentration of the blood is considered to be a deficiency that can be very severe. You can see in this spot of the map of the world. Of course, the iodine intake, which is very low, may be linked to severe form of mental retardation in the offspring, and of course because the iodine intervene in many areas of the development of the brain, particularly in neocortex, in the cochlea, in the ganglia, and so on. So the iodine deficiency has been found to be in the world the first cause preventable of mental retardation worldwide. So it's a still very big public health problem, which should be faced, because now we don't only need more intake of iodine for the pregnancy and lactation, but many dietary restrictions, many attitude of women, they have decreased very much the iodine intake, in particular, as you can see here, data which are pertaining to vegetarian or vegans in the United States, and the amount of iodine in the blood is particularly low. So the iodine recommendation, according to different international associations, is at least to provide 150 to 200 micrograms a day. This can be obtained also with access to iodized salt. So this should be promoted as much as possible. And finally, I would like to open a very big parenthesis for the omega-3. What are the omega-3? I don't enter in detail because we are not making a biochemical speech, but I have to let you know that what we have as a long chain polyunsaturated fatty acid may be divided according to their promoter fatty acid, linolenic or alpha-linolenic and so on, and categorized in omega-3, omega-6, and according to this to have different final fatty acid in production. Now the story of omega-3 is very long. It started almost 40 years ago when it was observed by epidemiologists at the beginning that the very rich diet, they have some northern population of Europe with particularly fish which are very fat, were not linked to an increase of cardiovascular disorders or other problems. Not only this investigator, Dr. Olsen, which was working in Faroe Island, which is a located between Norway and Iceland, he found that the population of offspring of mother which have a nutrition mainly based, a diet mainly based on fish, fat oil containing fish, they were bigger and they were very low preterm birth rate. So starting from this observation, they start a randomized controlled trial on the effect of fish oil supplementation on pregnancy duration. And this has brought to a lot of research which show that particularly one of the derivatives of the omega-3 DHA, which is containing high-fat fish but not in vegetable oils, is incorporated in the brain and the retina of the developing fetus and has been linked to the decreased risk of premature birth and of postpartum depression. Not only study which show supplementation of this particularly fatty acid DHA on a breastfeeding mother show that the child's visual cognitive development was increased, was faster, and there was less allergy and infection in this child growing up. So the evidence now, we have a more 70 randomized controlled trial which have shown clearly that the supplementation of omega-3 from the beginning of pregnancy may reduce early preterm birth by 40%. And this is in link with the amount of omega-3 levels that we have in the blood of the mothers. And of course, the deficiency of this particular polyunsaturated fatty acid, which we call omega-3, the deficiency may be a contributing factor for the risk of preterm birth in many populations around the world. As I said, the fetal brain increasing gestational age incorporate DHA for almost 60% of all the fatty acids which are part of the central nervous system, but also in the retina. It is particularly important because these low-chain polyunsaturated fatty acids enter in the neural membrane particularly in the photoreceptors. So this is in link with the fact that now the maternal dietary DHA intake is constituting an asset for the best development of central nervous system and influence brain and retinal development in the baby, decrease the risk of preterm birth, and reduce the postpartum maternal depression and allergy in offspring. And this data, which as you can see has been reiterated also by recent trials, show that the supplementing also the starting of the second trimester get better result in the visual acuity and the language development of a baby afterwards. So this story, which starts from the fish, a very happy ending and leads to healthier neonates at birth. Australia and New Zealand have issued guidelines for obstetrician midwife to implement the use of omega-3, rich of DHA, for the mother, for the pregnancy. And of course, even where it is not possible to measure the content, because it's not easy to measure the content of DHA or omega-3 in maternal blood, it's better to supplement these ladies. So in coming to some conclusion, I think that nowadays focusing on human nutrition is one of the best aspects of our profession. FIGO already a few years ago started a campaign called Think Nutrition First, in trying to focus and optimize adolescent maternal nutrition health, starting from the preconceptional years. And this approach is thought to have considerable positive benefits for ensuring not only the woman health, but also the offspring health, also for the future generation. So what is the best way to adequately provide micronutrients through the station? But I think that the balanced diet nowadays, what we call mainly a Mediterranean style diet, should consider fish twice a week for the omega-3, whole grains for the folate intake, with adequate source of vitamin B12, iron, iodine, and also vitamin D, which has been discussed by others. I think that this Think Nutrition First, you can download the free from the FIGO website, has 10 points which are so important in which the appropriate nutrition healthy lifestyle and combined with the control of BMI, which are all modifiable risk factors for pregnancy, are important. And we have to pay particular attention to the toxic chemicals that nowadays are vehiculated through the nutrients, not only to the mother, but also, of course, to the fetus. And in the case we have to qualify the diet because of some problems in lifestyle, some problems in the mother diet and nutrition, I think that the effect of multivitamins for decreasing the risk of fetal malformation is much more than to give a single vitamin or single folic acid. This is a very important paper which was demonstrated by the late Professor Seisel, which was a distinguished epidemiologist looking to the fetal congenital disorders. He showed that it's not enough to give folic acid to decrease, for instance, neurotropic defect, but the association with, for instance, vitamin B and other vitamins may decrease further the risk of spina bifida, but not only, but the risk of cardiopathies, congenital renal disease, and so on. So, women nutrition health can play a role in the intergenerational transmission of the human health capital, ensuring future happiness, longevity, health, and economic progress. So, my final sentence is, for every mother, eat better, no more. Eat better means also to supplement with adequate vitamin, micronutrients, and minerals when the diet is not appropriate. Thank you for your attention.
A big thanks to Dr. Giancarlo for taking us through the nutritional requirements needed by pregnant women, as well as reminding us of how the benefits of women's health can secure the well-being of their children and of future generations. At last, we've reached our final lecture for today with the last member of our expert panel. He is a professor of obstetrics and gynecology at McGill University and University of Ottawa. He is also a national and international women's health specialist. Here to discuss nutrition and metabolic adaptations in physiological and complicated pregnancy is Dr. Andre Lalonde.
Nutrition and metabolic adaptations in physiological and complicated pregnancy. When we talk about nutrition in pregnancy, we want to talk about the development, origin of health and disease, and why it is important to have vitamins and nutrients in pregnancy. The origins of lifestyle-related disease is formed at the time of fertilization, embryonic, fetal, and neonatal stages by interaction with genes and the environment. And in this picture to my right, you can see environmental factors such as undernutrition, stress, psychological or physical stress, infection. This will increase internal stress. This will lead to a release of glucocorticoid hormones and increase fetal glucose load. In the fetus, this will induce changes in growth, organ structure, cell number, gene expression, neuroendocrine functions, and metabolism, and thus lead to adult disease. The placenta is an endocrine organ which produces several metabolic proteins such as leptin, adiponectin, peptide hormones, steroid hormones, cytokines, which have significant influence on establishing and maintaining a healthy pregnancy, regulating glucose and lipid metabolism, and their adaptation throughout pregnancy. Again, here is a pictorium to show the placental hormones and protein. We won't go through each of them, but this is available after the lecture. But you can see that each of these hormones or protein has a great influence on pregnancy and later on development of adult diseases. Approach to dietary supplementation. The determination of whether dietary intake is sufficient is based on, is intake sufficient, yes or no? If yes, what are the pharmacological indications, risk reduction, optimal function, and this includes life cycle, environment, behaviors. If intake is insufficient, can intake be achieved from foods? If the answer is no, then we can use supplements. Vitamin mineral supplementation in pregnancy in low middle income countries. Meta-analysis of 72 studies reviewed 314 papers and 451,723 women. Key birth outcome improvements with vitamin and mineral supplementation. Decrease preterm labor. Decrease small for gestational age. Decrease low birth weight. Micronutrient supplementation has no effect on maternal, neonatal, perinatal, infant mortality. However, we all know that mineral and vitamin supplementation, as well as good nutrition, will decrease maternal, newborn, and neonatal mortality. Iron folate supplementation improves maternal anemia and reduction of low birth weight. Lipid nutrition supplementation does not seem to have effect on outcomes. Single micronutrient supplementation is extremely important in various diseases. For example, preeclampsia, use of calcium, maternal anemia, iron, preterm birth, vitamin D, and zinc. So these will be looked at in much more detail. Efficacious dietary supplementation. Provide a nutrient normally undersupplied to cell or exert pharmacological effect on cellular processes. Benefit only when normal intake nutrient is lower when the normal intake of a bioavailable form of a nutrient is lower than the amount that would provide maximum benefit. Metabolic, environmental, and genetic factors can make individual nutrient requirements differ from estimated needs calculated from population-based data. And I will discuss this in more detail. Difference between individual needs and population needs. Understanding how variation in nutrient requirement comes about can identify individuals more likely to benefit from dietary supplementation. Example, intracellular antioxidants may be depleted and dietary supplementation might restore optimal antioxidant protection, which is essential both for the mother and the newborn. Variation in individual nutrient needs. Delivery of the nutrient in a person's diet is inadequate because of low food intake. Nutrient intake depended on official recommendation, but in reality, underestimation of the needs of an individual. Special conditions at a certain point in life of an individual causes requirements to change without corresponding changes in diet. And finally, supplement has pharmacologic effect to correct cell functions that became abnormal due to disease. Defining requirements. Recommend daily allowances based on needs of an entire population and is not based on individual, but based on healthy individual, and is also based on optimal intake of food during the whole pregnancy. Scientists hope to recommend nutrient that permits optimal cell function for most people. Bell-shaped distribution of the human population will show and highlight some of the problems with RDA. Factors in individual vary greatly: genetic, development, lifestyle, environmental, normal aging. Also, pathological conditions lead to underestimations. For example, here in this graph, you can see that the distribution of dietary requirement in a population. It varies among individuals. So you see here on the left side, number of persons, intake needed to meet requirements, and that leads to a bell-shaped curve which shows the average requirement, which is usually reported as RDA. However, this will miss 5% of the population, which has needs that are greater than a 2 standard deviation. And also that includes 1 standard deviation. Relative risk and dietary intake. At very low intakes of a nutrition, there's substantial risk of deficiency. At a very high level, there can also be a toxic amount. So here you can see this very clearly, that the average individual requirement is what is based for the RDA. However, safe limits vary, and it depends a lot on individuals. Example of different needs. For example, regular exercise can result in reactive oxygen derivatives, which can damage cells requiring increased dietary antioxidants. Another example, sunscreen use, increased age leads to need for vitamin D supplementation. Vitamin B12 needs are increased in elderly. Pregnancy, woman and fetus need more folate and iron. Deficient nutrition behaviors. Reduction of dietary fats lead to decreased fat-soluble vitamins such as vitamin A, K, E, and D, and therefore not recommended to have a very restrictive diet in obese women. Another example is that smoking leads to oxidant damage, thus requiring supplementation with antioxidants. However, if there's a damaged DNA, they can be dangerous to inhibit apoptosis, which is needed in cancer protection. When to use dietary supplementation? 2 reasons. 1, to optimize cellular function when nutrient in diet is low or inadequate diet or poor food selection. Second one, to obtain a pharmacologic effect that corrects abnormal cell function as a result of disease. So let's look at metabolic issues and supplementation in low middle income countries. This covers at least 2 billion people. There are key vitamin and mineral deficiencies. Pregnancy increased energy and nutritional need. Adverse outcomes in mother and newborn. We've seen that malnutrition in newborns is a high cause of newborn mortality. It's also a cause of maternal mortality. Nutrition may be responsible for at least 20% of maternal mortality in low-income countries. Micronutrient supplementation offers mitigation for these adverse events. So if we look now at one of the largest studies that was published in the last few years, 72 studies were reviewed, 314 papers, 451,722 women. Micronutrient supplementation led to improvement in preterm birth and decreased small for gestational age and low birth weight with multiple micronutrient supplementation. It had little or no effect on mortality. However, iron, folic acid supplementation shown improvement in anemia and reduction of low birth weight. Lipid nutrient supplementation had very little effect. What are the recommendations by major OB/GYN organizations? There are very few, if any, recommendation on micronutrients in pregnancy by major organizations, except for folic acid. For example, American College, Canadian Society, Royal College, Australian College, Mayo Clinic, etc. If you look up the literature, there are very few recommendations, if any, on micronutrients. So we need an international input from world experts on pregnancy to meet with nutritionist experts, PhD in nutrition, researchers, to come up with major recommendations to treat adequately women, not only in low-resource countries, but in all countries of the world. Now, a few important micronutrients, for example, leptin. Leptin resistance is important to maintain increased energy level and support fetal growth in second and third trimester. However, a very high increase in leptin can be predictor of GDM risk, gestational diabetes mellitus. Hyperinsulinemia in gestational diabetes would increase leptin. Inositol. This is seen in many cells, and 99% of inositol is seen as myo-inositol. Review of the importance of this in the literature, Cochrane Review, 4 randomized controlled trial, 502 women. These are smaller studies, but they're very important when they're grouped together. We see that a decreased incidence of GDM, more than 50% decrease when you replace myo-inositol. Recent meta-analysis of 5 randomized controlled trials with 956 patients confirmed the safety of myo-inositol in a reduction of GDM incidence. In conclusion, population recommended level of vitamins and micronutrients not necessarily helpful in individual needs of people. Pregnancy health needs, individual evaluation of diet intake and needs. Low middle income country pregnancies need more attention and research. Lack of recommendation on nutrition and micronutrient needs by major OB/GYN organizations are a concern. Vitamins and micronutrients are needed by most pregnant women in the world. Thank you very much.
Thank you so much, Dr. Lalonde, for reminding us that the publicly recommended nutritional guide for pregnant women may not serve the best interests of individuals with specific needs, especially those from low to middle income countries. Fellow doctors, our global panel has already covered a lot of ground tonight. But as mentioned at the start, today's exclusive plenary is all about deepening the conversation on maternal matters, which is why I'd like to invite back our panel so we can discuss some of the finer points of the nutritional needs of mothers and mothers-to-be. Please welcome back to your screens Dr. Otilia Perichart Pereira, Dr. Giancarlo Di Renzo, and Dr. Andre Lalonde. Welcome, doctors. Thank you so much for taking the time out of your schedules to be here with us today. We've already learned a lot from these various risks and challenges women face before, during, and after pregnancy, as well as how to prevent these risks through proper nutrition and supplementation. But I still have a few questions here that I'd like to ask in order to delve deeper into these topics. Let's start with Dr. Otilia. Based on your lecture and FIGO guidelines, adolescence is a period which should be given attention in the context of reproductive health. What supplementation should be started with adolescents based on evidence? Should you give them vitamin D, iron for those with heavy menstrual flow, vitamin B complex, and the like? Doctor?
Okay, thank you. Well, I guess the answer is we don't know, or it depends. As I said, there's very scarce evidence about optimal supplementation for adolescents or women in reproductive age. However, we have this Cochrane review about intermittent iron with good results on anemia and hemoglobin status, probably in heavy menstruating adolescents and or in high prevalence regions of anemia will be a good option, the intermittent iron supplementation. But there have been also some reviews of studies in adolescents without pregnancy that have shown that even folic acid with iron, micronutrient multiple supplementation will be improving hemoglobin levels or decreasing sometimes anemia. Zinc supplementation also have been shown in some studies to improve hemoglobin and serum zinc concentrations. And also another nutrient that has been studied scarcely but studied, calcium may improve hip bone mineral density and serum calcium concentrations also in this group. And two nutrients that I will be worried about will be vitamin D and DHA. Vitamin D really it's prevalent, the deficiency of vitamin D is prevalent like around all age groups, so probably adolescents will be a very, very important target group. To decide the dose, the ideal will be to measure concentrations, but probably will not be very cost effective. So to a very important, a thorough evaluation or assessment, nutrition assessment of lifestyle behaviors associated with sun exposures, about dietary, vitamin D, veganism, vegan, will be high risk. Obesity or dark skin pigmentations will be more high risk of vitamin D deficiency. So probably check how all these factors goes and decided if I go with a low dose vitamin D, probably at the level of intakes, or if we have that deficiency, probably a higher dose. And for DHA also, as I showed, we have very low intakes of DHA in the population, and probably if we don't have a fish intake, it's difficult to achieve the DHA. So it depends also on this lifestyle and dietary intake to see if DHA should be supplemented probably at the level of recommended intake.
I agree, Dr. Otilia. It really is hard to know which nutrients should be supplemented. In the ideal world, if we could measure all the micronutrient levels in these patients, then we will be properly guided. So I agree that maybe lifestyle and asking the diet of these patients will be able to guide us to localize the nutrients that we can give to these patients in our particular countries. Moving on to you, Dr. Giancarlo. Despite the recommendations and programs on right nutrition, supplementation, and proper care for the pregnant women, what for you are programs that should be initiated by governments and public health sectors so as to decrease morbidity and mortality?
This is a question that United Nations should address every day, as well as WHO. I think that is crucial that every nation or every region in the world consider what are the most important issues, the most important problems of morbidity and mortality of a mother and of her offspring, and try with specific programs to diminish, because adequate nutrition, adequate lifestyle, which they should together, for instance, also promoting exercise during pregnancy, may make the difference. Stop smoking, avoid alcohol, avoid toxic chemicals through the nutrients, promoting a healthy diet and so on, should be something that every government, the public health sector should start, but not at the time that pregnancy is already ensured. Should be start before, investing in the adolescent education, in the teenager education, not only females, but also the boys, because they should be aware of what is important in their nutrition lifestyle to make the next generation better.
Well said, Dr. Giancarlo. I agree that prevention is better than cure. So whatever recommendation the government or the health department of each country will give, it's ideal for us to give it even before these women get pregnant. My next question is for Dr. Andre. In the conclusion of your lecture, you mentioned that population recommended levels of vitamins and micronutrients are not necessarily helpful in individual needs of people. Can you reconcile this with the practice of many countries to routinely give the vitamins and supplementation at the national level just so to address potential deficiencies?
Excellent question. As I mentioned, I think that trying to find the right balance of vitamin and micronutrient needs for a whole population is very difficult, and we don't have the current research to tell us which individuals should use or not use vitamin and micronutrients. In the 9 months of pregnancy, there are many changes occurring. I mean, stress. Who knows that maybe the woman is stressed 4 or 5 hours a day. She may not tell me, the doctor, that this is happening. And therefore, that woman, which appeared to have a good nutrition, good food intake, would benefit from having multivitamins and nutrients. The same thing for women in low resource countries, which have a high morbidity and mortality during pregnancy, for their fetus, and from the newborn. So I think that this is why most countries now will use routine vitamin and micronutrient supplementation in pregnancy, because of the host of factors which can be happening during a pregnancy, which can lead to very adverse events. In order to prevent these adverse events, we then recommend vitamin and micronutrients to all pregnant women.
So as primary healthcare providers, we should give our patients multiple micronutrient supplementation. But if we can, if we know our patients personally, we know their deficiencies and their diets, then we may be able to target those micronutrients that they lack and give them what they need. I have another question for Dr. Otilia. In women trying to conceive, do you recommend taking baseline levels of certain vitamins and supplements like vitamin D and DHEA prior to starting them?
Yes, thank you. Well, I think that in many countries and in many contexts, this is not feasible. And it will take a lot of resources and a lot of changes to implement this. That will be ideally for vitamin D. I think the ideal for estimating the exact dose that we need to improve vitamin D status will be measuring 25-OHD. However, I think that in many contexts we can assess lifestyle behaviors, lifestyle in women, to see how much sun exposure they get or they can get, and probably go to the sun exposure. And we see in women that we know that lifestyle is not helping in improving their vitamin D status, in women with obesity and or morbid obesity, women with very dark skin pigmentation, probably we will need to start supplementation more if they are planning a pregnancy, because we need vitamin D for multiple processes, as I already said in the talk. And for DHA, I think it's really, we're not in the moment that we should measure DHA for all women. That will be incredible, but I don't think we can do it. I think we should focus on dietary counseling, and in that counseling, fish could be an important component of the diet that we should promote. Fatty fish, and also increase the alpha-linolenic acid sources such as nuts seeds, and flax seeds, for example. That will take more quantity to convert to a smaller quantity of DHA and EPA, but could be like a more dietary counseling orientation. In some cases, or when they are planning a pregnancy, probably if we have the resources, we could measure and decide the dose. Or also look, if we are not adhering to adequate fish intake, probably we should supplement at the level of intake 200, 300 of DHA milligrams.
I see. So if we can measure, that would be ideal. But if not, we can go to the history taking and ask them clinically if there's sun exposure or in their diets, so that we can supplement them as needed. This brings me to my second question for Dr. Giancarlo. To ensure adequate supplementation during pregnancy, would you recommend a combination of multiple micronutrient supplementation, or is giving iron, folate, iodine, and DHA enough?
If I would consider the legacy of Professor Zeisel, which has demonstrated quite clearly that it's much better to give a multi-supplementation tool than just the single micronutrient, I would be in favor to recommend a multiple macronutrient supplementation. This, I think, for two reasons. First, because of this study, which showed that the multiple macronutrients may prevent more, at least in percentage, let's say, negative outcomes, also in terms of fetal malformation, if appropriately given from the beginning of pregnancy. The second is that we are never sure, even with a good questionnaire, of what is the diet intake of a woman. Because, especially with the deviation there are nowadays in many parts of the world, or traditional foods that are used and so on, the lack of some nutrients, micronutrients particularly, is associated with the lack of others, which we don't consider, we may not evaluate in the blood of a mother concentration. Otherwise, we have to evaluate a number of macronutrients, which is impossible to do. And I think in this case, this justifies, at least the opinion I have, that it is better to use multiple micronutrient supplementation.
So since it's very hard to determine which micronutrient the pregnant woman lacks, then it's better to give your multiple micronutrient combination. Our last question for the evening is for Dr. Andre. What are the 3 most common issues in the post-pregnancy stage in the underdeveloped countries that should be addressed by the national governments and also by societies?
Thank you. This is a very important question. The issues that should be addressed by governments, for example, we know that there's malnutrition in women and newborns. And it seems that even governments who pride themselves in providing support in pregnancy do not provide that support in the postpartum and the newborn period. We also need to address the issue of male support. In many societies, developed and underdeveloped, the governments need to address that issue where there is a lack of support from the husband or the father of the child. Finally, in all of the countries, we need to see where the health system is failing to address the needs of postpartum and newborn women. We have seen this by the fact that in many countries, less than 20% of the women attend a postpartum hospital or clinic visit. And I would say that this should be many visits, not just one visit. In the first year postpartum, a woman should have at least 3 or 4 visits with her healthcare provider to really assess if the needs for nutrition and medication are met, and also the needs of the newborn. As far as the societies, the national societies, I think they have a very important role of advocacy. National societies need to meet with governments of their country, be it local government, regional government, national government, to advocate for postpartum health, not only for contraception, but also for development and for support of the woman who may have had a difficult pregnancy. We need to have training opportunities also for residents or for trainees, be it nurses, midwives, or physicians, to highlight this issue, which is often forgotten. And finally, I think we need to have more care available to women in the world closer to their homes. In many countries now, you're seeing that we have home care. And again, our national, international societies, medical societies, need to support this, need to promote this, and need to advocate for this in countries where this is not available.
Very good points raised, Dr. Andre. So each one of us, we have our responsibility. If we can help our societies become advocates, give more treatment or training, so that we can be able to apply all our learnings that we've gotten this evening, and that our patients will benefit from them. Unfortunately, that's all the time we have for questions today. But our experts certainly enlightened us with the knowledge they've imparted this evening. Before we end tonight's session, I'd like to invite our panel to share some parting words to our audience today. Let's start with Dr. Otilia.
So finally, I think that a good nutrition and metabolic evaluation is key to really orient us where we need to focus more. Probably supplementation will be important as a multivitamin, just iron and folic acid, but probably folic acid would need higher doses, but probably vitamin D we need to supplement, or probably we don't need to supplement vitamin D or DHA. So I think that correct nutrition and metabolic assessment is key for women planning a pregnancy, for example. I think that counseling, improving competencies on nutrition and good diet, healthy eating in all health professionals also is a relevant area that we should work on. Everyone should give clear messages about healthy eating, and we need to change behaviors around the world to improve metabolic status, mainly in women. And supplementation, we need more studies. We need to individualize. Supplementation is not just for yes or no answer, yes for all of them or no for any of them. There's very particular situation contexts that will lead us to decisions about what nutrients and doses of nutrients. And this is really to improve health across generations.
Thank you, Dr. Otilia. Now, Dr. Giancarlo, please.
I was very happy to participate to this workshop, let's say, web workshop, in which, along with my distinguished friends and colleagues, we discuss most of the problems related to nutrition in the preconception, during pregnancy, and postpartum period. As you have seen, there is a particular attention nowadays we have to pay more as obstetrician gynecologists around the world, as midwives, to the diet and nutrition of the woman, which is wishing to have a pregnancy, who is already in pregnancy, who has just delivered. And I think that this is particularly important because we neglect this aspect. We have to be more careful in, asking the patient, consulting, and eventually where we don't know what to do to, deliver the patient to our colleagues, which are more expert in nutrition, or they are diabetologists or so on, and they can, afford the different problems, because in many parts of the world, obesity is increasing, and these apply in some words to the 35 to 40% of reproductive female population. And this, of course, needs a careful evaluation, not only of the problems of obesity, but also which is the best nutrition, which are the supplementation to be given, and so on. So I think that we have highlighted some of the problems, but of course, there is very much to do, and also to sensitize all the population, particularly the young population, to adopt a new lifestyle, new nutritional, at least habits, which may be important for their future.
And of course, Dr. Andre.
My final words would be to my colleagues and to all of the professions is to work together in providing care for a woman, their fetus, and their newborn. And in my lecture, talking about also the postpartum period, we need to develop a collegiality amongst all professions so that a woman, her family, and the care of their newborn are addressed in a timely fashion for at least a year after each pregnancy.
Thank you once again to our experts, Dr. Otilia, Dr. Giancarlo, and Dr. Andre, for taking the time today to uplift our fellow doctors with the knowledge they need to not only properly nourish their patients, but also improve the health and well-being of future generations all over the globe. Thank you so much to my fellow doctors, our viewers, for being here today. Let us all utilize this knowledge to uplift our practices and clinics from today onward. Goodbye and have a great day ahead.
This has been Maternal Matters, optimizing nutrition from preconception to future generations. Thank you to all our viewers for participating in today's exclusive plenary brought to you by the Nestlé Nutrition Institute. We look forward to sharing knowledge and providing you with the latest scientific and practical nutrition information again soon.